Last time I covered how schizophrenia can be broken down into positive symptoms, delusions, hallucinations, and disordered thinking, and negative symptoms, apathy, loss of emotional expression, and cognitive deficits. I also covered how pharmacological treatment remains the mainstay for both acute and long-term treatment, even though it is only effective in treating positive symptoms and at the potential high cost of numerous debilitating and even permanent side effects. Parkinsonism, akathisia, motor restlessness, tardive dyskinesia, potentially irreversible chloroform movements, hyperprolactinemia, and agranulocytosis. This is what the mental health industry refers to as effective treatment for schizophrenia. So effective, in fact, that it is considered unethical, at least in the US, to study schizophrenic outcomes without their use. Again, the first pharmacological interventions used in the treatment of schizophrenia were compared favorably in the 1950s to lobotomy. And authors writing in the academic literature today still reference even these early interventions as effective treatments. But to dig further into the topic, however, I wanted to return to the 2016 Owen, Sawa, and Mortensen article from The Lancet, simply titled Schizophrenia, and the author's etiological discussion, that is to say, their discussion of the causes of schizophrenia. The dominant paradigm for understanding the environmental contributions to schizophrenia etiology has for over 3 decades been the neurodevelopmental hypothesis. This directs attention towards established risk factors for schizophrenia affecting early neurodevelopment during pregnancy. These include maternal stress, maternal infections, nutritional deficiencies, intrauterine growth retardation, and pregnancy and birth complications. However, socioeconomic factors, child adversity, and first and second generation immigrant background have also been associated with schizophrenia. There are also consistent reports of higher rates of schizophrenia in individuals born in late winter or early spring, in individuals born and or raised in cities, and in individuals where the father was relatively old, but also an association with young parents has been found. The association with advanced parental age has been ascribed to the increased rate of de novo mutations in their offspring. But alternative or complementary explanations have been proposed. More recently, evidence has accumulated implicating cannabis use in adolescence, in particular, misuse of compounds with high THC content. Also, several other factors, such as head injury, epilepsy, autoimmune diseases, and severe infections, have been associated with increased risk. Many of the associations with environmental risk factors appear robust. However, observational epidemiology suffers from the limitation that it cannot distinguish true causation from association due to confounding pleiotropy, the apparent reality that one gene can affect multiple traits, such that one mutation in one single gene can cause a disease with a wide range of symptoms, or reverse causation. Thus, at present, caution is required in interpreting these associations, and more work is needed before preventative intervention is justified. In summary, a large body of literature suggests that multiple risk factors, in particular those affecting early neurodevelopment, contribute to the etiology of schizophrenia. There is also emerging evidence that environmental factors, both biological and psychosocial, may impact at later time points. It is certainly possible that the effects on the developing brain of earlier environmental exposures, as well as genetic factors, increase susceptibility to these later risk factors. However, caution must be observed before inferring causality, and there is a need for studies combining measures of both the pre- and postnatal environment with measures of genetic liability. In summary, current understanding of the neurobiology of schizophrenia remains largely incomplete. There is strong evidence implicating dysfunction of dopaminergic neurotransmission in the genesis of psychotic symptoms, as well as evidence implicating abnormalities of glutamate signaling, which might help account for the negative and cognitive symptoms. There is some evidence linking specific brain areas, such as prefrontal cortex, to specific cognitive dysfunctions, working memory impairment, but the evidence also points to a widespread and variable involvement of other brain areas and circuits. The bottom line here, even with all the supposed potential or near understandings of the causes of schizophrenia, what it all amounts to is the academic equivalent of, yeah, we don't know. As Owen, Sawa, and Mortensen continue. Management and outcome. Beyond pharmacological interventions. While antipsychotic medication remains the cornerstone of treatment, the effective management of schizophrenia requires pharmacotherapy to be embedded within a framework of strong psychological and social support. These include approaches aimed at improving adherence, as well as vocational and educational support and rehabilitation. This requires a multidisciplinary approach involving a variety of healthcare professionals and agencies delivered in a community care setting. Specialist early intervention services, which focus on those who are experiencing their first psychotic episode in the following 3 years, are available in many developed countries and are popular with service users and carers. These have beneficial effects on outcome in the first few years, but their long-term implication remains uncertain. Psychological treatments have been mandated by current UK NICE guidelines, which recommend that everyone with schizophrenia should be offered cognitive behavioral therapy, CBT, and family intervention, as well as antipsychotic medication. A role for CBT is justified by evidence that various potentially mutable psychological mechanisms increase the risk of specific symptoms. However, the degree of efficacy and cost-effectiveness of CBT in schizophrenia is controversial, and there is little evidence that it impacts on underlying psychological mechanisms. One possibility is that the efficacy of CBT depends upon non-specific factors, such as the quality of the relationship between the therapist and the patient, therapeutic alliance, and there is evidence to support this in regard to schizophrenia. This last possibility, the authors note, should not be surprising, given that CBT, by its very nature, is controlling and manipulative, as I have covered elsewhere, centering as it does around changing clients' or patients' thoughts and behavior. That is to say, by centering around the client or patient conforming to the views of the therapist. Returning to the 2013 article, Why Do We Not Use Psychosocial Interventions in the Treatment of Schizophrenia? From the Australian and New Zealand Journal of Psychiatry, Harris and Boyce write, "The role of psychological and psychosocial interventions is not limited to the treatment of negative and cognitive symptoms. Interventions such as cognitive behavioral therapy for psychosis are of benefit in the treatment of so-called treatment-resistant hallucinations or delusions, and family therapy has long been acknowledged to be useful in reducing relapse rates in schizophrenia." While I have shown how Owen, Sawa, and Mortensen address this claim about CBT already, I will address family therapy and its relation to schizophrenia at a later time. But as Owen, Sawa, and Mortensen conclude, current treatment consists largely in the administration of antipsychotic drugs, combined with psychological therapies, social support, and rehabilitation, but there is a pressing need for more effective treatments and for services to be delivered more effectively. But where is the motivation? The financial incentives within the mental health industry are abundantly clear. For example, given the fact that of each of the set of authors I have cited thus far, both in this video and the last, in the case of each, at least the primary author had conflict of interest ties to the pharmaceutical industry. And again, it is considered professionally unethical to even study schizophrenic outcomes without pharmacological treatments, despite poor outcomes and debilitating, sometimes permanent, side effects, and so on. And culturally speaking, we see the continued call for more mental health care, even for a return to the state-run mental hospitals and even further increased coercive psychiatric care, with any realistic understanding of the massive shortcomings of this same supposed care absent, especially in terms of its explicit harms. Again, think of the side effects of so-called effective pharmacological treatments for schizophrenia when they only target the positive symptoms of the condition, or rather that is, 1/2 of the condition. Also concerning culture, there has been a considerable amount of discussion throughout the years connecting culture and schizophrenic outcomes. But I will pick back up with that next time. I hope to see you there.